Welcome to the Noobie Dentist Podcast, the safe place for newbie dentists to connect, collaborate, learn, and grow. The Noobie Dentist Podcast aims to provide high-quality and high-value content for all the newbie dentists out there. With your host, Dr. Omid Azami.
Hello and welcome back for another episode of the Noobie Dentist Podcast. I'm your host, Dr. Omid Azami, and I'm excited to be here with Dr. Raelene Sambrook out of Australia. She's traveled a bit in the past few years, but during her prosthodontics residency, she was faculty at the dental school, and she taught us a lot of our pros lectures, and I really enjoyed the way she taught. And we've been talking over the past few months, and luckily she gave us an hour of her time to come and talk some dentistry and some occlusion and some pros. So thank you so much for being here, Raelene. If you want to just go into your background and then we'll sort of jump off from there.
Hi, Dr. Omid. Thank you for inviting me to speak today on the Noobie Dentist Podcast. It's very exciting for me. So a bit of my background. I graduated as a dentist from the University of Queensland in 2000, and I worked as a GP dentist. During that time, initially, I started in a government position where I was doing both adult and pediatric treatment. After that, I then moved into more of a private role working with a health fund. And I guess I got to a point sort of at the 7-year mark that I needed something more. So I think what happens is when you're a new dentist, everything is quite new and exciting and you feel very challenged by everything. But at the same time, you also have a few moments of heart failure, and you soon learn where you don't go to avoid heart failure. So you can become a little bit conservative, and then when you become conservative, you also start to lose the excitement of the job. So
For sure.
For me, I then sort of reflected on what aspects of dentistry I liked and which ones I probably didn't enjoy so much and where I wanted to get better. And I guess at that point I made the decision that, I found prosthodontics probably the most exciting, only because in my mind it was sort of the most varied. So I enjoyed sort of the longer appointments. I liked the longer treatment plans where you got to spend more time with people and get to know people. I also felt that with the prosthodontics, it was a real life changer for the patient. So when you delivered some really nice cosmetic or aesthetic outcomes, it really sort of had an impact on the patient. And I think just the fact that it was so varied. So, in the early 2000s, we were looking at sort of, implant dentistry just becoming more mainstream for GP dentists. Mm-hmm. I really enjoyed removable, and then I also sort of really enjoyed the theory. So understanding material science, understanding occlusion, and I really wanted to get to understand treatment planning better. So, I was in a position where patients would come and see me and I knew they had complex needs, but I didn't have the skill set to be able to understand what the issues were and how to deliver an appropriate sort of solution for them. So I figured that pros was the space for me. I applied for University of Melbourne. And fortunately, I got in, and that's was awesome. Sort of where history started. Yeah, that's
pretty cool. So it's cool that you worked for. So I don't know, you worked so long before getting into pros. So what was sort of your how many years into it did you decide maybe I want to specialize? And after that decision, did the decision to specialize come first, or did the decision to do pros come and then you're like, no, I want to specialize in pros? You love pros so much that you're like, this is where I want to focus on.
Yeah, no, I think the decision, in actual fact, the decision was I needed to do something more.
Yeah.
So I undertook a lot of CPD training, and I felt that I was getting a lot of surface information that didn't actually give me sufficient information to tackle the problems that I wanted to. So I felt that if I really wanted to become an expert in something, then I needed to go back and really invest the time and effort to develop my skill set. So I came to the decision that I wanted to be better at something, but I really enjoyed all aspects of general dentistry. So, then I sort of had to make that decision, well, which do I like more? And I guess that's why I sort of explained before how I went through, a decision-making process, like what do I like about dentistry? What do I like less about dentistry? So, for example, I really hated short appointments. So 30-minute appointments all day, every day, set my mind crazy. Just being controlled by the ticking of the clock is something that really sort of
just adds so much stress.
Me out.
Yeah, for sure.
So for that reason, I knew that I didn't want to do something like orthodontics.
Yeah. Let the hygienist do all the work. The assistant do all the work. Okay, that's pretty cool. So what was like, and I've spoken to a few other pros residents from the States, Dr. Bedrosian and Dr. Mizumoto. They're sort of in their final years of doing training, and they're pretty active on Instagram, and they've sort of created this app called like Pros 365. So they're sort of posting cases they're doing every day in their residency. And for me, that was pretty cool because I felt that Melbourne, the PROS program didn't really give us like a full, fair, like perspective on what the specialty could be. So I remember in school, I was thinking like PROS is so like boring, like you just do like single crowns. And I feel like we didn't have enough exposure to like big cases and like full mouth rehabs. Not that we would do it, but even to like observe it or learn about it. So I feel like after graduating now, I'm like learning a lot more about PROS and all the different things and all the different modalities that and treatment options that they can provide. So what perspective of PROS did you have like in dental school and then in your first few years of working as an associate?
Yeah, I find your comments quite interesting actually, because I think one of the challenges of teaching prosthodontics is that because it encompasses such a broad area, it is really challenging to have you understand the complexity of cases without at least having the fundamental building blocks first. So obviously within the training courses, the intention is to ensure that when you leave your training program, you do actually understand, how to come to a diagnosis, how to treatment plan, how to execute the treatment. And then the purpose of your general dental training program is that once you leave, you can then build on those building blocks to become, once you've developed your skill set, then you can become more proficient and undertake sort of these more complex cases. But I also sort of acknowledge the fact that, we do have these issues where due to time constraints of the training program, you don't get the opportunity to see some more complex things. And I guess one of the programs that they run at the University of Melbourne are the back to basics programs, or, the little residency programs they have when they get everybody together in your final year. And the purpose at that point is to actually try and not only just go back over the theory of, the building blocks that you've been learning, but also then take the opportunity to show you how you can apply that to, the more complex cases. Mm-hmm. I think it's cool that those prosthodontists, though, are sort of, just trying to highlight what they're doing, because in all honesty, PROS is so cool that... I
swear it's so cool. Like, I had no idea. Like, honestly, like, I would, in Melbourne, I would sit in the lunchroom and like after a PROS lecture, and we're all like, literally like, who would become a prosthodontist? Like any dentist can do a crown, or like, it's like, and now I'm like seeing, and like, obviously the modern PROS, like surgical PROS, like implants, like all on fours, and all that kind of like stuff. It's so broad and it's so like exciting. So I've completely changed my mind, like in the past like year, having more exposure to it. And like, I realized I know nothing. Like I'm at work and beyond, like, like a single unit kind of thing. I'm just like, I feel like I'm so out of my depth with looking at a big case and trying to like figure out like what to do next. So I think it's pretty cool.
No, and I guess where you're at now is sort of where I was at as well, which is why I made the decision to go back and do PROS, because there are really complex cases which, which are really exciting to undertake. And when you get to the end of, in some cases treatment goes for years. So these people almost become part of your sort of, your little dental clinic family because they're there so frequently. And, I love pros. So, I'm a little bit biased.
That's all right. That's awesome. So, like I mentioned before to you, I do want to nerd out quite a bit and talk a fair bit about just general occlusion principles and ideas, because I know you lectured on it, and it's something that I personally want to review, and I think other people will find value in it as well. So before doing that, though, I want to sort of talk about your last few years, because I know I think the last time I saw you, you're sort of finishing up your training and you're heading overseas to do some more schooling and all that. So what have you been up to in the past couple of years?
So I actually finished my pros training in 2011, and then I worked at the dental hospital in Melbourne, the Royal Dental Hospital of Melbourne, for about 5 years. And at that time I was also lecturing and teaching at the University of Melbourne. Yeah. And then I think one of the challenges, if you don't go into, say, private practice, is that, an independent private practice as well, is that you're going to be working in some sort of larger organization. Mm-hmm. And the big concern that I have there is that there is really a failure of alignment between sort of the administrative or the management side of these larger organizations and sort of where the mindset of the clinicians are in terms of delivering care and improving health outcomes. Yeah. So I guess I made a decision that looking at the bigger picture long term, one of the ways that we can actually improve health outcomes is by improving the efficiency and the effectiveness of, say, for example, dental health programs that are government funded. Yeah. So I made the decision that, in order to be able to communicate effectively with management people, I needed to be able to speak their language, because there's no way that someone who's a manager is going to go do dentistry and pros to sort of, get where I'm coming from. Yeah. So I was really lucky. My husband has a UK passport, so we were able to go over to Switzerland, and I did an executive MBA at the University of Lausanne, and I finished that in December. And nice. And now he has a job in London, so I am looking at moving there.
That's awesome. So that's pretty cool. I see a pattern emerging of, you don't want to sort of, if you're going to do something, you're going to go all out and do it. So you wanted to learn pros, so you do a residency. You wanted to learn some executive lingo, so you do your MBA. It's pretty cool. Pretty respectable as well.
Well, what's really interesting with the executive MBA is that we spent a lot of time sort of being forced in a way to reflect upon ourselves and how we operate. Well, you do a lot of things looking at group dynamics and how groups work, but a big part of that is who you are and how you interact with people and how people perceive you. So I actually came to the realization that I'm a details person. So I need to understand the detail. And if I don't understand the detail, then I have a malfunction in my brain. So this is the underlying issue for me.
It's not an issue. I think that's the right way to do it. You want to be comprehensive. That's awesome. So that's pretty, just from like my personal standpoint, I've always thought about the idea of doing an MBA as being pretty cool, because maybe not as noble as your pursuit of it to like get on the community health and be more efficient at that. But from my end of things, I wanted to think maybe like later on in my career, if I wanted to sort of branch out and, maybe get into like managing a few practices and building something that way. So what do you think, like in terms of people you met or your experience in MBA school, is that something that like a general dentist in private practice could benefit from? Or do you think it's a little bit like too much? Like we don't necessarily need to go through all that to be able to effectively like lead and manage like multiple offices or anything like that?
Look, I think because you're on the job and when you are forced to manage people, you probably learn a lot about business. So, for example, my friends and my colleagues who have their own practices, there is no doubt that they have they had a better base knowledge of how, dental practices work and what they need to do in terms of, improving patient inflow and managing staff and all of those businessy aspects.
Mm-hmm.
What I think was great about the MBA, though, was that I was in I think I was extremely fortunate, but I was with a fantastic group of people, and you're not learning about things just from a dental perspective. So I actually saw outside of the dental world, and it was like, oh my goodness.
Yeah.
And it was really cool to learn about a lot of things that I never thought that I would ever learn about. So not that I actually enjoyed learning about all the finance things. So that actually was really, really hard. That was like you guys learning occlusion the first time. Having to learn all the accounting terms was really traumatic. But no, but just having a basic, learning about economics and understanding demand and supply, and now being able to listen to the business report on the news and actually understand about inflation and, interest rates and all the rest of it. We also did some other really cool things. So, one of my lecturers was a business ethics teacher, and his course was really amazing and really got you to sort of think about where is your point of reference in terms of your ethics. We also did a great course in negotiation, so actually learning how to actually understanding the theory of negotiation and learning that negotiation, you should be thinking about what is the shared value. So not just thinking about what you get out of something, but understanding how by working together you can actually improve what everybody gets out of a negotiation.
That's great.
We did supply chain, and I decided that if I hadn't have become dentist, I would have done, I could have been awesome at supply chain management.
It's not too late.
Looking at processes and identifying how you can improve processes and ensure that everything sort of moves as efficiently as possible. So that was really interesting. And then, of course, the advantage of the MBA that I did at Lausanne was that they also had a healthcare focus. So
nice.
We had a special interest group at the end where we focused on, subjects specific to healthcare. So that included therapeutic innovations, so understanding the challenges that big pharmaceutical companies face in terms of remaining innovative and yet having to meet the challenges of, meeting share market expectations. We did another subject looking at health technology assessment, so actually understanding, what is the cost of healthcare to society, and when we implement a new screening test or a new medication or a new technology, how much does that actually cost and how do we measure the benefits? And then we also did healthcare strategy and marketing. So actually trying to understand, how do you create value for your customer, identify your customer, what is their willingness to pay, and all the rest of it. So the point, though, is that I think by doing because I'm a detail person, but by doing something really comprehensive and being forced into actually committing to that study, a very, very hard 15 to 18 months, particularly if you're working. But at the end of it, you come out an extremely informed position, and I think you are in a really great position to be able to make informed decisions that enable you to be successful.
That's awesome. That's pretty cool. There's a lot of good information in there. And I think it opens up a lot of options for you, right? So have you thought about what you want to do with, the combination of qualifications that you have now once you get over to the UK?
Yes. So I have a position lined up, which I'm very excited about. Nice. So that's working for a dental supply company. So that'll be looking at procurement of new products, identifying, what products may not be selling so well and how do we sort of either invigorate or get rid of them, looking at supply chain. So, how do we improve services to customers? What are the customers' concerns about, how do we improve our service to our customers? And obviously I want to get back into prosthodontics as well, because as I said before, pros is cool.
Yeah. That's pretty cool. And so I've talked to a few dentists actually from the UK on this podcast, and a lot of them are not too happy about the public sector, the NHS system and the fees and everything associated with that. So going over there now, do you think you can have any role to play with, obviously once you've been there for a while, in terms of like policy? Because I feel like even within Melbourne Dental School, we had a few of the dentists and the demos and all that. They were from the UK that they come over. So there might be a bit of a brain drain from like dentists leaving because of the NHS fees. Have you thought? Is there anything that you can potentially do with that, or?
Potentially. It's really interesting actually, because I did go to what was called a 5-day return to work course, which was run by the NHS, and that was fantastic because it gave me an opportunity to sort of understand how the NHS manages their dental program.
Yeah.
And what's really interesting is they changed the rules a number of years ago, and the purpose of that was to try and change the philosophy of how treatment was being provided. So beforehand, it was sort of the more you did, the more you got paid. And then they changed the solution to try and make it that that there was more of a preventative focus and people weren't over-servicing. But unfortunately, we now have, we now sort of have this situation of not so much, I don't want to say supervised neglect, but in some ways, you get paid the same amount regardless of how many restorations you do. And so if you're treating some patients who are poor dental attenders, well, then we have this situation where they might be coming in and you have to then provide, 10 or 15 restorations, and you're getting paid the same amount as if you only do one restoration.
Wow. Okay.
And the reality is that, if you want to be able to focus on good quality treatment, how do you do that? So I think the bigger challenge is how do we actually make patients more responsible for their mouths, because the issue is that dental disease is preventable.
Yeah, that's very interesting. So let's change it up a little bit. I'm hoping to maybe pick your brain a little bit and talk some pros. So I've been, I haven't done a whole lot of crowns this year. Over the past few months, I've slowly been doing a little bit more. But I'm finding a lot of times when I get these cases back from the lab, I cement in the crown, especially, with like upper 7s or lower 7s. I'm having a lot of issue with the occlusion of it. A lot of time spent polishing afterwards, especially like on excursive movements. The patient's always like, oh, no, it's not quite right just yet. So I'm hoping maybe I can pick your brain a little bit and we can talk about maybe how you approach a case. For example, you're preparing an upper 7. What are you looking for before you prep? What are you assessing in the occlusion? And after your prep, after you temporize the tooth and get the crown back from the lab, what sort of things we should be watching out for? Just to try and make things a bit more efficient and better workflow, so we're not spending a whole lot of time polishing and scratching up our beautiful little crowns that we're getting back from the lab.
Okay, so the first thing that I would be making point is that before you place any crown, you should be assessing what the occluding contacts are on that teeth, not only in maximum intercuspation, but also in excursive movements. So trying to understand, on that tooth, before you actually prepare the tooth, do you have contact in excursive movements as well as maximum intercuspation? Because the reality is, depending on, say, the amount of canine guidance that a tooth has, depending on the amount of canine guidance that exists in the person's, mouth, what are the contacts going to be in the more posterior region? So if you do actually have wear on the canine, then you may have more of a group function.
Yeah.
So it's always good to sort of analyze and understand your situation before you get started. The second thing is, that's why it's always good to have a set of diagnostic models as well, because when you're working on, say, a very posterior tooth, it can be quite challenging to actually see what is going on. And by virtue of your articulating paper being, several microns thick or whatever, you can actually record more than what does actually exist. So a set of models is always, or if you have like an intraoral scanner, looking at it, on the three-dimensional model is actually quite good, because then you can actually see if there's any wear faceting and seeing if you've got contact in those excursive movements. So then the next thing would actually be preparing your tooth. And then, of course, I always try to check the inter-arch space in functional movements after I've prepped the tooth as well. So it can be really challenging holding a mirror in there and seeing. But if you've prepped 2 millimeters off a 7, then you should be able to see space between the tooth that's prepared and the opposing arch, during the functional movements.
Yeah.
Another good way to check your inter-arch distance is actually when you prepare your provisional or your interim restoration as well. So what is a good technique to get into is actually making sure that after you've prepared your interim restoration is to use a set of calipers and just make sure that you've got appropriate thickness.
Okay, nice. Very thorough.
And that's why some clinicians will actually prepare their provisional restoration before they take their impression, because it gives you a means of actually assessing that you have adequate
I've heard that one. Yeah.
Then after you do that, then you take your impression. Now, the thing that's really important is, depending on your type of impression, can actually influence the inter-arch relationship as well. So when your patient opens up wide, the mandible, particularly in the posterior region, can pull inwards slightly. So when your models are poured up and articulated, you can end up with a slight difference in, occlusal relationship on the models relative to what you have in the patient's mouth.
Yeah.
The last thing that's really important is when you get your crown back from your technician, if you have it on a set of models, you should be actually checking trying to hand articulate and move the models around to see whether or not your technician has actually been respectful of the inter-arch relationship as well. Because it's not, like I've had situations where the technician has on, say, a person who has something which is like a 60-year-old dentition, so, pretty flat cuspal inclines, provided me with a lower 7 or an upper 7, which has the same cuspal formation as as an 18-year-old. And you're like, well, it's obvious then that in excursive movements there's going to be, some discrepancies there, and then you're going to spend a lot of time actually adjusting in the patient's mouth as well.
Yeah, for sure.
But what's also important is that when you prepare your provisional restoration, you need to make sure that you actually maintain the same occlusal contacts as you had before you prepared the tooth. So if you actually think, to make it easier for myself, I'm going to reduce the occlusal table of the provisional restoration, leaving sort of a space between your tooth and the opposing tooth, well, then there is a potential risk that because you don't have that stable contact, there could be movement of those teeth.
Okay, that's interesting. And in terms of taking impressions, obviously in school, maybe part of the reason I didn't like pros so much was you had to take impressions, go make a special tray, come back. There's a lot of work involved. So I have been a bit lazy perhaps, and we use a triple tray. And I've had some labs, because I try and talk to the labs a fair bit to try and get feedback on my preps and all that, try and improve it a little bit. And a few of them have told me the triple tray usually works pretty well, but sometimes the bite can be a little bit off. So it's always better to take a separate upper and lower, even if you're just doing not a full arch, but just a quadrant, just do separate.
Sure.
So what's your opinion on triple trays, and is it okay to use them for routine single unit cases, or?
I mean, some prosthodontists will say you should never use a triple tray, and then there's other prosthodontists who, for a single unit, would always use a triple tray. So I think that they can be used quite effectively. Some people would say you should never, you could use them when you have contacts on either side of the tooth, use them for all situations. Probably the most important thing when you're using a triple tray, though, is making sure that your triple tray is rigid, because if it's not rigid, you can end up with some discrepancies.
Yeah.
And the second thing is actually making sure that when you seat the triple tray, there's no interference and it's seated correctly, and that the patient actually occludes together correctly. Because if all of those things aren't correct, then the information that you're actually sending to the technician is incorrect, and then you are going to end up with, an incorrect replication. And I guess that's why the technicians are sort of saying to you, maybe you should be providing an upper and lower impression, because what it does is it gives them an opportunity to actually analyze the patient's occlusion and ensure that what they've received in the triple tray impression is correct relative to when the patient has the full arch.
Mm-hmm. Okay.
But the challenge that you have, though, is that really, if you are using a triple tray, it's important that the patient has canine guidance and no contacts in excursive movements. Because if, for example, the patient if they don't have canine guidance and they have contact in an excursive movement, well, then you're not going to capture that in your triple tray.
Okay. So another case that, comes through the doors pretty often, and so far I haven't been too sure, how to treat it or how to manage it, is the older patients that come in that haven't been to a dentist in a long time. And the posteriors seem okay. There's a bit of like wear facets on the posterior region, but their anterior region, they sort of have like that edge to edge, like classic bite, and there's like a massive like semicircle wear like on all the front teeth. And there's not much restorative space because you can't like build the teeth up really, because then the posterior teeth will be like discluded. So in terms of a new dentist coming in and seeing a big case like that come through the door, how would you sort of recommend they sort of manage it? Obviously, even if it entails like requires like referring it out to a pros, but in the initial sort of assessment, what things should we be looking for? What things should we be checking? What records should we be taking so we can make that educated treatment plan for the patient?
I guess the first question would be, is it of concern to the patient?
Yeah.
And how much wear actually exists? Because the reality is, over a lifetime, we are going to have wear on our teeth. And so is the wear that we're seeing, abnormal wear, or is it really just wear associated with the patient's age?
Normal function, yeah.
Is the patient concerned about the wear? Because obviously as clinicians, we're sometimes more concerned about things than what the patients are. So, does the patient have any sensitivity? Do they have any increased mobility? Do they have any, any other concerns related to their teeth? I guess the other question would be, how long have they actually had that wear for? Because we don't know, if we're seeing a patient for the first time, we don't actually know how long their teeth have been like that for. And this may have been something which happened a long time ago, or it might be something that they're only just, noticing at this point. And then once I've sort of elucidated answers to those questions, then it would be, well, does the patient actually want to do something? Do we need to try and prevent further wear from happening, or does the patient then want to actually have some sort of treatment to manage the wear for either functional or aesthetic reasons or whatever? But really it's that, you need to sort of understand where the patient's mind is at, because, unless they actually want to seek treatment or they want to prevent treatment, then really there's not much more that you can do except for acknowledging that there is something there, and you've tried to understand and gain a diagnosis of the issue, and then provide the patient with the option of sort of management or treatment, either through referring or whatever.
Okay, that's pretty cool. So that's a lot to consider there. So in terms of, for example, like a patient, just like a bit more of cosmetic side of things, they've come in and they're not happy with like their wear on their like anterior incisors, the uppers. A lot of time I feel like this is like from experience, like I've built them up like with just composite, and like a month later they're like chipped the back off, or it's broken back off. What things am I missing? Am I not like making sure like in excursive movements there's not interferences? Do I have to like maybe build up the canines a bit to like restore like a different sort of canine guidance. Just for something simple like that most people would maybe face in their first, year of working. What would be a good way of making sure like your anterior buildups don't fail?
Well, this is the challenge, isn't it? Because why is there that missing tooth structure in the first instance?
Yeah. So
the missing tooth structure is there because the patient probably bruxes their teeth. And what we know about bruxing is that, the number of episodes, the frequency of episodes, and also the force or the load on the teeth during an episode can vary dramatically as well. So if you're just putting on these small little, repairs in composite resin, and you're bonding them using our special, glue called dentine bonding agents, then, what are the chances that they are actually going to survive excessive load? And in particular, the load is not necessarily along the long axis of the tooth. It's, it's that sliding load as well.
Yeah.
So this is where sometimes you think that you're doing the right thing, and what actually ends up happening is it becomes a very expensive exercise for you because the patient has paid the money, and then you're having to see the patient and repair the issue and all the rest of it. So the first issue is acknowledging that the reason why the patient's tooth has worn is because of some sort of parafunction. Now, we spoke about bruxism, but, what else do people do with their teeth? They do really ridiculous things, like they chew their fingernails, they pull off lids from stubbies, they they eat ice, like they do a lot of things which puts a lot of load on those restorations that you've spent so much time sort of getting to look really, really nice. So the question is your little restoration really going to be able to last the test of time? And that's when then sometimes, in order to have, sufficient bonding and structural integrity within the material itself, you may need to consider veneers. But then, of course, veneers are more expensive. The patient's investing a lot more money, a lot more time, and they're still under those same stresses as well. So there is a risk that they might fail, and then when they fail, they're a much bigger problem for you as well. So this is where sometimes we sort of do things because we think that it's a good idea, or we think that it will look better, and then we run into this predicament where treatment doesn't actually play out as we were hoping, and then we're left sort of responding to quite an angry patient.
Yeah, for sure.
Because you said this would work.
So I think you have to setting expectations is something that I'm learning a lot this year. Is really important to do. You gotta really
Absolutely. So I mean, if a patient's coming in and they have this wear on their front teeth, then the thing that you need to make them aware of is that enamel is one of the the hardest materials in our body, and somehow you yourself have actually damaged it. So I can put something there, but the risk is the forces which have caused the wear of your teeth are actually going to cause this material to fail as well. If you really want to give it a go, we can, but I can't actually provide you with any guarantee that this is going to last, unless we do something like provide you with a night guard that you wear every single night. And then that's going to reduce the load on those restorations.
And it puts
See what I mean? It's horrible cycle.
But you put the onus on them to make sure they wear their night guard, so it's their fault if it doesn't break. That's pretty cool. And
we have to.
Yeah, go ahead. Sorry.
Oh no, but you have to, because how can you control what they do?
Exactly. Yeah, and I think that's something that you learn in your first year, because you take everything so personally. Like if something fails, you're like, "What am I doing wrong? Like, what's wrong with me?" And then you kind of start to learn that obviously nothing's going to be permanent in the first place, and second of all, if the patient's doing something that they shouldn't be doing, or they have parafunction, basically, like things will fail. So that's pretty cool. So the last thing I wanted to get your opinion on before we go here is, so for posterior, obviously like materials now, obviously like we had like the gold, and then we had PFM, and now, we had lithium disilicate, like Emax, and zirconia is coming up now. What's your opinion on using something like an Emax for like a posterior, like a single unit, like on a upper 6 or a lower 6? Would you trust the strength of that, or would you do like zirconia or PFM still over Emax?
Yeah, that's a really interesting question, actually. In all instances, it's real. Well, and I keep coming back to the same sort of the same question is, what's important to the patient. So the first thing that I'm going to discuss with the first thing is that the patient needs some sort of restoration which provides cuspal coverage to protect the tooth longer term. So that's the first diagnosis that we've come to. We're then going to look at what is the visibility of that tooth when the patient smiles and when the patient talks or when they're in function, to get an idea of how much you can see the tooth.
Yeah.
Once we have an understanding of the visibility of the tooth, then we're actually going to talk to the patient about what different materials exist. Now, one of the advantages of, say, gold and monolithic zirconia is that, or non-precious metal, is that the amount of occlusal thickness you require is substantially less than if you're doing a porcelain fused cement or you're doing an EMAX.
Yeah.
So another factor that's going to influence your decision making in terms of what you're going to recommend to the patient is what is the actual height of the actual tooth. Because if you're working on, say, a lower 7 and you have, say, 4 millimeters of tooth structure, well, the last thing you want to do is actually reduce another 2 millimeters to ensure you've got adequate space for your lithium disilicate, or 1.5 to 2 millimeters for your PFM as well. So understanding the tooth is important, and then understanding what the patient's aesthetic requirements are is important as well. So if my patient says to me, I don't care, I just want what lasts the longest, I'm going to say to them, awesome, we're going to do gold or we're going to do non-precious. Do you prefer gold? Do you prefer silver? What do you want? Okay, So we've established that they're going to go down that path.
Yeah.
If they say to me, I want white, I'm going to say, if the height of the tooth is quite short, then I'm going to say to them, look, the only option we really have is a monolithic zirconia. And then I'm going to explain to them that the monolithic zirconias, although they're white, they can have actually a high value, or they're quite bright. So if the tooth is visible, it may actually glow a little bit, because that's what zirconia does. Now, if somebody is driven by white teeth, they're usually not going to be concerned that the zirconia is too white for them, all right? And then the consideration then is PFM or is a lithium disilicate going to be a more appropriate restoration? Now, for me personally, in the last couple of years, I was practicing before I went away, I was probably more inclined on, say, 6s and 7s to do the monolithic zirconia. Further forward in the arch, though, so generally on a 4 or a 5, I was probably doing lithium disilicate, only because I think the colour of that material is much more natural than what you get with the zirconia. The other thing to consider as well, though, is historically they were using zirconia for anterior restorations, and they were doing it as a layered restoration. So in essence, the core material was zirconia, and then they were using layered porcelain over the top. And then they had problems with the layering porcelain actually fracturing away from the core, and in part that was due to not really understanding the relationship between layering porcelain and the zirconia and the heat transfer and the rest of it. So another important thing to appreciate is that the use of monolithic zirconia is still somewhat in its experimental stage, in the sense that we don't really have a lot of evidence that shows categorically that, monolithic zirconia in thin cross-section in the posterior region of the mouth is actually going to be, that it can actually withstand the trauma that it experiences sort of being in the posterior region of the mouth. So the caveat that needs to come with your monolithic zirconia is that, well, I can offer you this white filling, but we don't have a lot of evidence at this point in time to support it.
That's pretty cool. And it was interesting with zirconia. I was listening to a podcast a while back. Unfortunately, I forget who it was that said it. Their opinion was that they don't use zirconia for any restoration because it's so indestructible, and they want things in the mouth to sort of, if they're going to fail, because it's better for it to fail than to just have this solid, like, indestructible like object in the mouth that's not going to fail or wear at the same rate as like the other teeth. So I thought that was a pretty cool sort of way to think about it. So I just wanted to see what your opinion was. And from my side of things, I think maybe because we're not as confident with our preps, the EMAX, the bonding adds a little bit of added security maybe. So
yeah, sure. So yeah, that's an interesting comment about the use of zirconia. Look, the reality is a gold crown can last in the mouth for a very, very long period of time. But if you need to remove a gold crown, your ability to remove the gold crown is a lot easier than what monolithic zirconia is going to be by virtue of the material itself. And so, you know, if you use sort of a metal cutting burr, you can, you know, cut through the metal crown quite quickly and then flick it off. Whereas with zirconia, you're literally having to, you know, re-prepare the tooth, which is quite challenging.
Yeah.
The people who seriously hate zirconia are endodontists. So you put a zirconia restoration on a tooth and then the tooth has pulpal issues and they see the endodontist, and the endodontist is really cursing the use of zirconia. Look, you know, who knows what's right or what's wrong? I mean, that's in some ways, it's the unknown that makes dentistry a little bit exciting, isn't it? Because we only know what we know and we know what the limitations are. But, you know, if the patient is insistent on a white restoration and your options are, and you're looking at a lower 7 or an upper 7 and your options are monolithic zirconia, PFM or EMAX, you know, it's going to be which is most conservative of the tooth structure. Because, you know, I am aware that things fail long term, but I'm not planning for failure. I'm not thinking that at some point I want to cut this crown off.
That's a good way to approach it. And it's funny because so I work in an emergency office like one day a week, and obviously like we work from a lot different dentists like in the area because they come in as an emergency. And I'm finding there's a lot of teeth that get crowned that there's pulpal issues after and they flare up a little bit. And obviously with your experience, what do you think like some actionable tips that we can do while prepping a vital tooth to try and minimize that risk? Obviously I've heard one is like a lot of people like over dry the tooth like before taking an impression or something, and that causes irritation. So is there any other tips that you have that we can minimize the risk apart from being conservative of tooth structure?
Yeah, no, that's exactly right. So I think in the first instance, any tooth that I'm going to prepare for a crown, I always replace the core. Well, it depends on what type of restoration you're doing, whether you're doing sort of an inlay, overlay type restoration, or whether you're going to replace the core and then place a crown. But the first thing you really need to do is pulp test the tooth and ascertain that it's responding in what is a normal manner for that tooth. Mm-hmm. The second thing is remove the existing restoration, because that will give you a good indication of how close you are to the pulp of the tooth. And it also sort of, if the tooth is going to flare up straight away, then it may flare up sort of after that appointment. Mm-hmm. Your comment was exactly right. You need to be mindful of the preparation requirements for the material that you're going to use and try and be as conservative as possible while actually ensuring that you're providing the adequate restorative space that's necessary. And that's where, say, for example, coming back to the discussion of zirconia, zirconia is a far more conservative restoration than, say, what a porcelain fused to metal is. Actually, it's quite interesting because there are some studies looking at the differences between, volume of tooth structure loss. I can't remember the names of the authors, but there's some really cool papers to read, actually appreciating how much tooth volume is lost when you're repairing a tooth. But what's also interesting when you're looking at those papers is just appreciating how even though the difference in volume loss may not be significantly different between a porcelain fused and metal compared to, say, a lithium disilicate. Yeah. The issue, though, with the porcelain fused and metal is that by having a 1.5 or a 1.75 preparation depth on the buccal, you are getting a lot closer to the pulp than if you do, say, 1 millimeter circumferentially. Obviously, the faster you can do things and have less trauma to the tooth is good. But I think also another important consideration is just ensuring that when you provide your interim restoration or your provisional restoration, you're ensuring that the tooth is well sealed. So you have, good margins on your provisional crown relative to the preparation line. Mm-hmm. And then I think the tooth obviously suffers a little bit of trauma if you do a resin cement rather than something such as a GIC cement.
Yeah.
And then the reality is, if a tooth has suffered that much trauma that they have needed a crown and then they've had a crown, the chances are that little pulp is going to shrivel up and die at some point.
That's a good way to approach it. That's awesome. Thank you so much. There's a lot of information in there. I think a lot of people are going to find a lot of good value in it and learn a lot. So I'm definitely going to, I think I need to read up on it a bit more. And you've kind of motivated me because, not to say I'm going to go do a pros residency now, but I think I'm going to spend a bit more time to get a bit more detail and learn things a bit more in depth and occlusion and indirect restorations. So thank you so much. I wish you all the best with your move back to the UK and everything. I'm sure you're going to do a lot of great things over there, and definitely stay in touch, and we'll hopefully do another episode of these in the future.
Cool. Thanks so much for having me.
Take care.